if that's something you're interested in. Susie here is working on, we've already had some success in making sure that your local first responders will be armed with Narcan now, so they'll be able to do that in the field, and I think that training will be done probably by the end of this month, for sure. And then we're also looking at how do we develop an education program for those providers who want to give patients Narcan kits, so that if you have a patient who is on chronic opiate use, on high dose and maybe is at risk for having an accidental overdose, you would write a script for that family member, and then they would have that available if they actually found their family member or loved one unconscious. So we're working on that. I'm missing, what else are we missing? Dr. Steinecker, too, has been part of the needle exchange program, because at the needle exchange program, it would be multidisciplinary. We would offer, oh, I know what it was. It was Connie. Connie's also been working on how do we do a better job of merging addiction specialists and primary care doctors, because a lot of doctors are afraid to look for addiction because they don't know what to do with it when they get there. So Connie Kerrigan and Marcia Hoff are working on, with a group of people, how do we facilitate the diagnosis of addiction and then get people into the resources they need. Is that it? Is that all the? Mm-hmm. Well, funny you should ask that. One of the things we did and will be presented tonight is research on how accepting are people of this concept, and we certainly need to do more marketing and more research. But what we found was that most people didn't like the idea, but they knew we needed it. And what was very encouraging, because they realized exactly who was mentioning who's going to pay for that, they realized they were going to pay for that. So pay me now or pay me later, and most people are smart enough to realize pay me later has a surcharge. So I think it's going to be something that will get pushback. I don't think it's anything anybody really wants to do, but I think most people understand this has been around for many, many years. There's a lot of research on this. It does not encourage drug use for people, and it actually is a really good preventive tool for HIV and hepatitis C, which, as I told you before, we've had, about a 20% increase, Erica, on that, on hepatitis C cases. So I just want you to know that we don't want to be Scott County 2.0. We want to be prepared for that and ready to go. They did a masterful job in was it one doctor really that kind of figured out that all these cases were occurring, or there was one doctor in that county that was seeing these patients?
Yeah, there was one physician, local physician, that was the primary care provider for the entire area. It was really our disease intervention specialist working with that doctor to identify, okay, this is a unique cluster. We really need to make sure that this, we start testing more contacts, and the combined effort of different local resources was, it was incredible to see both entities working together to help combat this.
And this is a community problem that deserves a community response. So if you're interested in helping on these teams, just let any of those people know, or let me know, or Jennifer know, and we'll get you to the right person. But this is a great segue into Kathy's talk, because of what's happening in Scott County, we want to make sure we're not looking at our numbers annually. We want to be looking at them every quarter to see if we start seeing an increase in folks. And that's what she's going to talk about today. So turn over to Dr. Steinecker to formally introduce her.
We made a decision to aim for an increased number of short 15 to 30 minute discussions, lectures, as opposed to hour-long sessions. And so I just want to show of hands, would you prefer having multiple smaller segment vignettes like we had today? And how many would like that? Raise your hands high. Okay, how many would prefer to have had a little more in depth and go, say, 30 to 45 minutes, 45 minutes to an hour per lecture? Okay, raise those hands high. Okay, I think we know we have some direction for next year. Our last person is Kathy Thorenson, the Director of HIV/STD Surveillance, and she's going to talk about HIV/STDs in Allen County. Thank you, Kathy.
Clicker up there?
The clicker's right.
Okay.
Well, good afternoon, and probably new news that there may still be another speaker that might get to your little, the mani-pedi may arrive yet, correct? Or maybe in the house? I hear. Okay. Well, I'll try and just kind of briefly go through this information with you, and it ties very closely to a lot of Caitlin's information. It just zeroes in very much on Allen County. Okay. There. Okay, there were handouts that were at the back table because I know a lot of numbers get hard to see, but oh, I hit it so firm we went flying right by the big story. Just starting out with trying to give you a feel for the information, which I think Caitlin did in the state map of Indiana. But we looked at data from 2013 and 2014, and really the overall picture, knowing that from CDC, we tend to look at chlamydia, gonorrhea, early syphilis cases, and HIV. Those are the ones that our surveillance is very concentrated on, and it's what the disease intervention specialists work with as far as all the partner notification and follow-up components and the prevention education. What we found in 13 to 14 was basically we were seeing a small downward trend, which always seemed encouraging. But when we started taking a look at the information for the first 6 months of this year, comparing it to that same time period of last year, we're seeing, well, no, that's not quite the story, because everything seems to be on the upswing this year a little bit in those disease categories. The HIV component is the one that I kind of wanted to bring to this group because of Caitlin's discussion, but we took a look at the 9 cases that were new cases diagnosed in this area and really took a look at the risk because of the needle exchange components, things that were going on in southern Indiana. And in the risks that we were finding, we continue to see that men that have sex with men continue to be our highest category of the risk of newly identified individuals tend to have. We did have IV drug use in our 9 new ones that were all of Allen County. But in addition to that, we also had 3 new ones because Caitlin's crew was constantly sending partners up this way if there was something that linked them to Allen County. So our staff would go and look for those individuals. If they were able to find them, they would test them if they were willing to. So there were 3 additional positives. They were in treatment centers here. Because that wasn't their residence, they're not in our statistics. They'd be in the statistic for like Scott County if that's where they originally were from. That's just how CDC keeps their information. Another piece that we seem to concentrate in the health department is really looking at the pregnant individuals. The gonorrhea and the chlamydia cases, as you saw in those earlier charts, is quite extreme. We've seen over 1,000 cases of chlamydia so far this year alone. What we did is a couple years ago, it seemed like we were seeing so many pregnant and also infected, we thought we better pull up specific information so we could see what was really going on. We did find that gonorrhea definitely was present. We found lots of chlamydia. We also found co-infections. What we wanted to do, though, was to be sure for the health of the baby and give the prevention education was to make sure that these individuals were getting their adequate treatment, that the follow-through was being done with partners, and that the CDC recommendation for rechecks was being accomplished as well. So we have an individual that she spends a ton of time on the phone with the physician's offices, the hospitals, the clinics, and gathers that information. She just keeps calling back to see if they made it in for their recheck appointment. So if I look in the chlamydia in the bottom part there, the number of chlamydia rechecks last year was at 60%. This year it's hovering about the same at 58%. Really, as a community, as a whole in Allen County, we should be able to bring that number up considerably. So that's going to be one of the pushes I think you're going to hear from the public health, talking to the rest of the health community over the next number of months. Same thing with the gonorrhea infections. The rechecks were actually going in the wrong direction so far the first 6 months of this year, so that too will be on the try and make it a focus. HIV testing. as Caitlin pointed out, it's so critical to get the populations tested that need tested, and certainly with the amount of science and what's available now for treatment, if someone is pregnant and HIV positive, it's so much more beneficial if they know their status early on. So we did make a focus to look at the HIV information to see, of these women that were in the positive gonorrhea or chlamydia groups, how many of them were getting an HIV test? Because it is recommended they get tested at their first prenatal visit and then also in the 3rd trimester. And in just looking at last year's data, only 44% of those individuals that had already a high-risk STD were actually HIV tested in that recommendation. This year, because we've been continually trying to do that education in the community, we're seeing a great improvement, 72%, but we still got that last leg that I think we can easily do here in Allen County. Some other information of updates for here in Allen County is just to make everyone aware. How many of you have seen this purple item floating around anywhere yet this year? Okay, so we all live in our own little specialty areas, I think, but this is kind of like the Bible of the treatment guides from the Center for Disease Control. It has recently been released. This is the website where you can go, you can get copies for your area. The larger panel is one that can actually be hung up, and then there's a little flip cheaters guide. It's just got the latest and greatest. It's taken all the recent studies to give you, at a quick glance, information for what the best treats are, what's going to be an alternative if you have, someone with allergies or someone with numerous other issues going on. So that's the treat guide. So if you have anyone that's working with sexually transmitted diseases or young adults, definitely they'd want to know that website and get access to it. Busy slide, worst slide ever award would go here, but it was just so busy, and I just wanted to point out there are 9 new areas that they really highlighted in that treatment guide that are really important that as a community to be state of the art, we probably want to bring ourselves up to date on. The biggest thing, since Dr. McMahon asked me to just talk about the sexually transmitted diseases, is to know that the treatment for gonorrhea has not really changed. It is still Rocephin and a gram of azithromycin. The thing that changed in this year's information was really going to make sure people understand dual therapy, stay away from monotherapy because of the amount of resistance. And every one of these categories in here has great detail in here in that treatment guide. On the HIV scene, they've recently released the new national strategy that moves on to the next 5 years of 2020. Many of these things are spot on with the things Caitlin had pointed out as steps that were taken with the group in Scott County and in southern Indiana. It is nice to see that we're able to move through this disease, take advantage of the research, take advantage of the science, and be able to make really positive impacts to reduce the amount of virus in the community, the whole viral load. So again, really this is up here more for you to just get the website. It's a good one to download, has an awful lot of information. Another thing in HIV and STD, just for community and having the opportunity to have so many partners all in one room, just kind of wanted to share, this is so much kind of the story of networking, I think, with peers, because these 2 posters we ended up printing here, but it was through the connections. I believe it went from New York creating this to Atlanta, from Atlanta to Indianapolis, and from Indianapolis to Fort Wayne, where everybody kind of personalized but got this information. So the collaboration that continues to move through public health is good and it's powerful. We used these 2 different posters in a variety of arenas, not only to promote testing and to promote people to think about prevention, but we also targeted special populations. We took the posters once we created them, we added a little drop area, so there are these little pull cards that are specific to our clinic. And as you can see on this picture hanging on that back wall, this is a lobby of a hotel here in Fort Wayne, which Dr. McMahon can be proud of. That's our little sign. It's in the lobby of a hotel. but just trying to place these in places in areas where we know we're seeing higher morbidity, things that we're trying to reach out and get people thinking. They might not be ready to test, but we can get them thinking. These are the cards that we placed inside each one of these. And again, you talk about the collaborations that can occur. These are the coolest things. They're little business cards. We had high school students from Anthus Career Center. Graphic design was their specialty. We did a presentation to them about some HIV and STD information and things going on in our community. And then they created a whole campaign for us. And in these, they designed this logo. They came up with these cards, and these are now the little cards that identify where our clinic is and how people can reach out to us. And the Up to Us, we just thought was really cool that they came up with such a neat idea. The young man explained it. He came to our board, and he explained that the lines going through there were actually graphs. And it was empowering the teens of the community to take on this issue, to be aware of it, and they wanted to start seeing the trends and the percentages to decrease. And just knowing that your public health, we're out there, out and about, in the streets, in the trenches, doing all those little fun jobs that people say, what would Deb McMahon say about this? Does anybody have any questions? It was just a real quick update for you. Because I see our other gal has arrived. So you get the mani-pedi. Thank you.
Which will be Natasha Allison, Dr. Natasha Allison from Bluffton, who is going to talk about the dangerous mani-pedi. So thank you.
I would like to please.
No, we just need 1 minute to.
Oh, okay. Oh, okay.
There you go.
Okay. So this is. Go ahead.
You just need to press for.
Okay. Okay, perfect. I would like to introduce our research project that I completed and my team completed during my residency in 2015. Name of project: Estimated Prevalence and Cost of TB among Asian nail salon technicians. I would like to thank Dr. McMahon for the idea of this study, and my team, who included Dr. Wilson, Dr. Eigner, Jenna Sanders, Nicole Hartman, Steve Williams, and Dr. Khan. As we know, TB cases are concentrated among immigrants and driven by reactivation of latent TB infection. Screening for latent TB, followed by preventive care, helps to reduce TB burden in high-risk group. Applicants for immigrant visa and refugee status are required to undergo a medical examination before being allowed to travel to the United States. Then newly arrived refugees are tested for TB, and when they apply for changing their visa status, their immigration status. Those who has negative TB test may travel to their country of origin and be exposed to tuberculosis and not undergo repeated testing, repeated screening. Non-immigrant visitors, such as exchange students, travelers, and temporary workers, also contribute to the burden of foreign-born TB in the United States. They may require to undergo medical examination by decision of a consular officer or immigration officer in United States port of entry. Another problem is high rates of non-adherence with existing guidelines of screening for TB. Study included Boston primary care facilities showed only 43% of immigrant patients were screened for TB. Currently, TB incidence rate among Asians is the highest if compared to other ethnic groups. The nail care become a booming industry over the past 2 decades. It's a common job among the new Asian immigrants to low start-up cost, minimal requirements for English and short training. Indiana Professional License Agency is issuing manicurist license to applicants who are at least 18 years old and obtain 450 hours of manicuring education. There have been several TB outbreaks connected to Asian nail salons in the United States in recent years. There are few cases on this slide. In 2007, case of active TB was confirmed among Vietnamese nail salon employees in California. In 2012, a similar case occurred in Howard County, Indiana. Among the 800 contacts, 11 people tested positive for latent TB. In 2013, active TB case was diagnosed in Ohio, where customers of nail salons were exposed to TB by nail technicians, and it resulted in 10 latent TB cases. In order to prevent local transmission of tuberculosis, we wanted to identify and treat Asian immigrants who have latent TB and work in nail salons in selected county, in Allen County. The purpose of the study was to identify prevalence of latent TB cases and estimate cost of TB contact investigation and treatment of active and latent tuberculosis. This was design of our study. We used cross-sectional and prospective design, and setting was Asian nail technicians in selected Indiana County. Our inclusion criteria involved both genders, age 18 and older, Asian, foreign-born, or native-born working in nail salons. After IRB approval, at outreach public health nurse approached owners of 11 Asian nail salons using prepared script and handout, offering screening for latent TB among employees. After consent, health department planned to administer tuberculin skin test as a primary screen and chest X-ray as a secondary screen for latent TB. If treatment of latent TB or active tuberculosis was needed, cost of treatment would be provided by Indiana Health State Department. But the problem was that we could reach 9 of 11 owners, and unfortunately, employees and owners refused to participate in study, refused to be screened for TB. So we decided to model the framework to determine main outcome measures. And on the slide you see that measures were number of potential latent and active tuberculosis cases, and estimated cost of tuberculin skin test and treatment active and latent TB cases. We used data from studies conducted in the United States, published literature, and data from local health department. Since Vietnamese salons represented more than half United States nail salon industry, prevalence of latent TB in Vietnamese was used for calculation, and it was used like 36.7%. Reactivation TB rate among foreign-born was used as 5.9% per 100 person years. We used fact that untreated patient with smear-positive TB infects in average 10-15 people a year. And smear tests can diagnose up 60% of cases of pulmonary tuberculosis in well-equipped laboratories. The number of Vietnamese nail technicians was 264 in Allen County on January 10, 2014. According to Nail Magazine Industry Statistics, average number of clients for each manicurist is 1,057 per 1 year. On the slide you see cost of treatment of active TB and latent TB and cost of tuberculin skin test was $15. This slide showing results of study that predictable number of latent and active TB cases were 97 and 6 respectively. Potentially 3 cases would be with smear-positive tuberculosis among manicurists, and 51 clients will have latent TB. This slide shows the total cost of treatment. Total cost of will include approximately $161,000. Cost of treatment of active TB of 6 cases is almost twice more than treatment of latent TB cases. An expected cost of tuberculin test for TB contact screening is $54,000. Of course, our study had limitations, and I would like to share with you. The true prevalence of latent TB was not identified due to refusal of this hard-to-reach population participate in this study. However, the study was completed using existing research and statistic data. There were multiple barriers encountered during this study. The owners of nail salons were not easily accessible. Often they were living not even in Indiana and different states. We tried to use phone line to reach them. There was lack of real understanding of TB disease process, language barrier, fear of owners that salons would go out of business if TB case is diagnosed. Our limitation of knowledge of Vietnamese culture, and our lack of use interpreter service. It also should be noted as limitation, the study did not take in account unlicensed technicians, so real number would be higher. This study did not include cost of multiple interviews, site visits, case management, data collection, exposure environment assessment, protocol development, and many other factors. The study included only one-time tuberculin test performance. I would like to remind that if contacts of high or medium priority, and if they don't have documented TB test, previous positive TB test, they should receive skin test as soon as exposure was identified. And if we retest these contacts in 8-10 weeks after exposure, actual cost of tuberculin test will be higher. So total cost of implementation would be $206,000. The study did not reflect ventilation conditions in nail salons, duration of contacts, number of co-workers and customers who could be also exposed to TB. Delayed diagnosis and treatment may aggravate the patient condition and facilitate transmission. If ventilation is poor and contact is closed and prolonged, even a single case of smear-positive TB with diagnostic delay suggests significant implications. So, what is conclusion? Estimated cost associated with TB among this population would be significant for limited resources of public health departments. TB remains an important public health concern in our communities. It's important for public health to identify high-risk populations and create culturally appropriate interventions to address vulnerable groups. Each community must determine how to allocate funds to effectively manage their specific TB-related issues. In this information, our research may assist local or state TB programs to develop policy for pre-employment and periodic screening for at-risk population. So we suggest that TB testing should become part of getting license for nail technicians from high-risk countries. Regardless of age, persons who fall into high-risk categories with positive skin test and who have not previously had treatment for latent TB would recommend treatment unless it's contraindicated. Treatment of latent TB is fantastic within drug efficacy studies and actually pretty bad in real life. 9 months daily isoniazid regimen has efficacy of more than 90% if taken properly. Unfortunately, not everybody complete these 9 months of treatment. In some places in the United States, only 20% of patients complete treatment. So every effort should be made to begin appropriate treatment and ensure completion of entire course of treatment for latent TB infection. We recommend a periodic screening for those people who recently was in country for high TB rate. And currently in the United States, there are no guidelines for people who refused to take treatment. So the emphasis instead should be on teaching patients the symptoms of TB disease. On this slide, one of these women is actress T.P. Hendren. She sparked the nail industry in 1975 when she had a group of Vietnamese refugees trained by her manicurist, and she was beginner of Asian nail salons in the United States. Do you have any questions? Okay. All right. Thank you for attention.
She's going to use 1, 2.
Okay, that is our afternoon of learning and education. I'm glad you all like the shorter sessions. There was a lot to be learned. What I do want to do, though, is because we are really interested in what you think, you did have evaluations that were handed out to you at the time you signed in. Would you please complete them? Any ideas you have for a future, next year's get-together, CIDNAC, and TB instructor update, we would love to hear. Also, those who are instructors, we gave you an evaluation of the TB 101, how we have transformed our TB education for those who administer and read TB test. Please make and add any comments and leave those with us. I assume maybe the table is still out there that you all signed in at. Just leave your evaluations there. But before you leave, I want to again say thank you to everybody who put this together, to Dr. McMahon, as always, Dr. Steinecker, who I believe has already left, and I'm thrilled to have it here. I think it was an excellent location, and so we appreciate being able to have it here at the Merrill Center. And to all our presenters who were fabulous and giving us an update on what's going on in the world of infection. Do you have a question? The instructor cards. Oh, the instructor cards, we had noticed the date is not accurate. Sorry for that. So what we will do is we will mail you the correct cards with the dates, just so you know that. We'll take care of that. We'll fix that for you.